Welcome to this video on EGFR and cancer treatment, where we will explore how targeting the epidermal growth factor receptor impacts physiology, malignancy, and mechanisms of resistance. We begin with Part 1, focusing on the EGFR receptor and its role in normal physiology. EGFR is a transmembrane protein of the receptor tyrosine kinase family, also known as ERBB1 or HER1. The interaction between EGFR and its ligands follows saturation kinetics, as described by the fractional occupancy equation. This understanding is key for designing effective monoclonal antibodies. The structure of EGFR includes an extracellular domain with a ligand-binding pocket, a transmembrane domain, a juxtamembrane domain for regulation, a kinase domain for phosphorylation, and a C-terminal tail with docking sites. EGFR, or HER1, is part of the ERBB family, which also includes HER2, HER3, and HER4. HER1 binds ligands like EGF and is widely implicated in various cancers. Moving into Part 2, we will explore EGFR's critical role in cancer. In healthy tissues, EGFR signaling is tightly regulated and ligand-dependent. In cancer, this regulation is lost through overexpression or mutations, leading to constant, ligand-independent proliferation signals. EGFR overexpression is significant in several malignancies, including head and neck cancer 90%, colorectal cancer 80%, and non-small cell lung cancer 60%. EGFR signaling contributes to the hallmarks of cancer by promoting proliferation and enabling apoptosis evasion via the PI3K/ACT pathway and inducing angiogenesis through VEGF upregulation. Key downstream pathways driven by EGFR include MAPK for proliferation, PI3K/ACT for survival, JAK/STAT for survival and inflammation, and PLC-gamma for cell motility. Part 3 will now cover the process of epithelial cell transformation, a crucial step in cancer progression. The transformation process begins with hyperplasia, followed by dysplasia and carcinoma in situ. Finally, it progresses to invasive cancer driven by EMT and protease secretion. Epithelial mesenchymal transition, or EMT, is a critical step where cells lose adhesion and gain invasive properties. Aberrant EGFR signaling is a strong inducer of EMT, driving metastasis and therapeutic resistance. EGFR activation upregulates EMT-inducing transcription factors, repressing E-cadherin, and loosening the cellular structure. This simultaneously upregulates mesenchymal markers, providing enhanced motility and invasiveness. We now begin Part 4, focusing on monoclonal antibodies as a strategy for targeting EGFR. Anti-EGFR monoclonal antibodies, or mAbs, block the receptor via two main mechanisms: competitive inhibition by binding to domain 3, and steric hindrance, preventing the necessary conformational change for dimerization and subsequent activation. Cetuximab and panitumumab are two key anti-EGFR mAbs. Cetuximab is a chimeric IgG1 antibody with high ADCC activity, while panitumumab is a fully human IgG2 antibody with lower ADCC activity but higher binding affinity. The efficacy of these antibodies relies on three key mechanisms: signal blockade, receptor downregulation, and antibody-dependent cell-mediated cytotoxicity known as ADCC. Anti-EGFR mAbs are critical cornerstone therapies for metastatic colorectal cancer, accounting for 60% of their clinical utility, and head and neck squamous cell cancer, accounting for 30%. Part 5 will now explore EGFR variants and mutations, which significantly influence treatment outcomes. EGFR alterations include gene amplification, deletions, and point mutations. These structural changes affect the receptor's function, activation state, and responsiveness to therapy. The EGFR VIII mutation, common in glioblastoma, involves a deletion that prevents EGF binding but forces the receptor into constitutive, ligand-independent activation, driving tumor survival. In non-small cell lung cancer, mutations primarily affect the intracellular kinase domain. These are typically targeted with small molecule tyrosine kinase inhibitors, not monoclonal antibodies. Extracellular alterations, like EGFR VIII, often lead to resistance to monoclonal antibodies by altering the binding epitope. Conversely, kinase domain mutations, common in NSCLC, make tumors highly sensitive to small molecule inhibitors. Finally, in Part 6, we will discuss the factors governing treatment response and the development of resistance. In metastatic colorectal cancer, a wild-type CRAR and NRAS gene status is an absolute requirement for clinical response to anti-EGFR mAbs, with a response rate around 40% in wild-type tumors. Mutations in KRAS bypass the EGFR block, resulting in constitutive downstream signaling. This renders anti-EGFR monoclonal antibodies completely ineffective, necessitating KRAS testing before treatment. Even when initial therapy is successful, treatment benefit is temporary. Selective pressure eventually leads to the emergence of resistant subclones, driving disease progression in all cases. Resistance occurs through several mechanisms, including the activation of bypass signaling tracks like MET or HER2, acquired downstream mutations in KRAS or BRAF, or new mutations within the EGFR receptor itself. We now move to Part 7, where we will examine cetuximab binding variants and the resulting mechanisms of acquired resistance. Cetuximab binds specifically to domain 3 of the EGFR extracellular domain. This binding is a precise lock-and-key interaction that sterically blocks the binding of EGF, preventing receptor activation. The S492R mutation is the most significant acquired resistance mechanism, replacing a serine with a bulky, positively charged arginine in domain 3. This substitution causes a severe steric clash, physically blocking cetuximab binding. The S492R mutation shows differential binding effects. While it completely abolishes binding for cetuximab and panitumumab, it has no effect on ligands like EGF or the second-generation antibody nicitumumab. This underscores the need for alternative strategies. Next-generation strategies to overcome resistance include antibody mixtures like SIM004, pan-HER inhibitors such as afatinib, and antibody-drug conjugates which use the mAb as a drug delivery vehicle.